Management and TM.
Hi, thanks everyone. You know, what we're trying to do with this workshop is cover some very common symptoms that patients have with TM, and probably about 75% of patients with TM do have spasticity, and so it's a very common problem. And the one good piece of news is that we have a lot of good treatments for this problem. So, while it may be more difficult to recover motor or sensory function, at least spasticity is something that we have some things that we can use for to make it better. So, this is a disclosure for if we're doing continuing medical education for physicians, but I think it's important that you know where people get funding, and I don't personally get any funding from any drug company or anything, and want to also let you know what the FDA says about some of these treatments that we're using, so that you know, we don't confuse you with information about off-label uses of stuff. Much of what I'm going to talk about isn't actually, they're drugs that are approved by the FDA, but they aren't approved for spasticity and transverse myelitis specifically, and you should know that. So I want to talk about how we'll assess spasticity. What are the things that we ask and examine when we see patients with spasticity? Talk about the difference between generalized and localized impairments from spasticity, which we treat very differently. And then talk about some treatment options for these upper motor neuron syndromes. Consequences of spasticity can be rather severe, and it can really impact how you move, how you're able to exercise, and how your joints are able to go through range of motion. And because of that, it'll interfere with your activities of daily living, getting dressed, getting on and off a toilet, even feeding yourself if it involves your upper limbs. It often causes pain and sleep problems, and we'll have a talk from Dr. Newsom later about pain, but at least 50% of patients with spasticity have severe pain from this spasticity, and it's one of the major sources of pain in transverse myelitis. And for caregivers, it can make life difficult too. It can, you know, if the person's not able to dress themselves and they're very tight, it may be difficult getting on a shirt or a pair of pants. In the worst case, and I apologize if people are eating lunch, but in the worst case, it can look like this, where somebody's really severely contracted, unable to move, and even getting some pressure sores from the spasticity. So it can be really horrible, and we don't like it to progress to that point. So sorry about your lunch there. But it's also important to recognize that spasticity actually has some beneficial things to it as well. And we don't want to totally get rid of spasticity in all patients, because some of this actually helps us. When your muscles are weak, if you have some spasticity, some tone in the muscles, that can help you move better. In particular, it can help support your circulatory function. So it helps push the blood from your legs up to your heart through your veins. So if you have some tone in your muscles, that's a good thing. It can help prevent blood clots, which are a major problem with people with paralysis. So we want to make sure that they're able to have their blood circulating. Sometimes it can be of assistance with activities of daily living. Having some muscle tone is good, particularly if it's muscle tone that helps you stand up or helps your trunk keep erect. So we want to make sure we maintain that. Some people wouldn't be able to stand up if it weren't for their tone. And so we always want to look for that and make sure that we don't over-treat things when we're treating spasticity. And it can even help with walking for the same reasons. The main thing that we worry about with spasticity are those contractures, like that picture we just saw, is that the muscles tighten up to the point where they can't move at all. And when we look at people who have contractures, have the tightening of the muscles, the question often becomes is how much of that's a mechanical problem from the muscles actually being shortened or the bones fusing together over time, and how much is a spastic problem or something that we're able to move through. And so a mechanical contracture is a fixed contracture, something that we really can't move through. And it can come from the tendons or the ligaments getting shortened. It can come from what we call a Charcot joint. So when the joint loses innervation and you don't have good sensation in the joint can get fractures in it, and it can start to fuse together abnormally, and that's what we call a Charcot joint. You also get a condition called heterotopic ossification. It's a condition where you get abnormal growth of bone into the muscle across a joint, and that can limit your range of motion. On the other hand, a spastic contracture is dynamic. It means you can move through it. So when you slowly stretch it out, it'll move through it. You can palpate as you're moving through it. You can palpate that the muscle that's working against you is also contracting at the same time the muscle that's supposed to be contracting is contracting. When we test reflexes, when we use that reflex hammer, we'll see increased reflexes. But when we're talking about contracture, most often both of these things are going on at once. And if you try to treat one without treating the other, you wind up getting nowhere. So it's important to stretch out those ligaments and those bones at the same time that you're treating the spasticity with medications or other treatments. So when we come to examine a patient with spasticity, when you go into the doctor's office, they should be asking you some questions about it. First of all, where are you having the problem? You know, what muscles are involved? Talk about what time of day it's happening. Is it at nighttime, for example, and keeping you up at night? What are the aggravating or alleviating factors? What makes it better? What makes it worse? It's often useful, and I often tell patients when they come back to see me, bring a diary of when you're having problems. When are those spasms occurring? Are they painful? And then we really want to know, how is it impacting you? What kind of function is it impacting? Are you having trouble getting dressed because of it? Are you having trouble walking because of it? And then we want to also ask you, how's it helpful? You know, are you using that spasticity to stand up? So when we want to examine people, we want to do a standard musculoskeletal exam. We want to measure your range of motion. Those devices that are pictured there are for measuring range of motion. It's called a goniometer. We also want to do, of course, a good neurologic exam. And we want to look for what's called clonus, or shaking when you push against a muscle. And there's something called an Ashworth scale, where we actually use a modification of it. But there's a way of quantifying how much tone you have. And you may hear your physician or your healthcare provider talk about your modified Ashworth score, and it's scored from 0 to 4. You can see the scoring here. What I like to do with my patients, and Dr. Becker alluded to this as well, is that you really want to know what the patient's goals are. You know, we really strongly at Hopkins believe in patient-centered care, and really thinking about what does the patient want to accomplish. And when you're talking about treating spasticity, you want to have some goals. And when we talk about goals, we like to talk about what we call SMART goals. SMART is an acronym. It means specific, measurable, achievable, realistic, and in a time frame. So we just don't want to say somebody will walk better. I mean, that's kind of a nebulous goal. We don't know whether we've made any progress or not. So what we would say is, we want you to be able to walk 25 feet with a walker in order to get to from your bed to the toilet. And we put a time frame on that, maybe within the next month or within the next 2 months, so that we know whether we've achieved it or not. And what we like to do with treating spasticity in a given area of the body, or a given medication that maybe we're using for more generalized spasticity, is ask patients to identify at least 2 of those goals. And then when we come back for the follow-up visit, we ask them how well they do at achieving those goals. Now, when it comes to treating spasticity, there's a whole bunch of things available, and this can be very confusing for patients, very confusing for physicians, quite frankly, in terms of what treatments are appropriate for what patients. And so there's a lot of good things that we have available, but we have to figure out what's appropriate for what patient. So we have everything from medications by mouth, we have various types of injections. The neurosurgeons can do some things in terms of even operating on the spinal cord in some cases. There are tendon lengthenings that the orthopedic surgeons can do. There's, of course, lots of physical therapy that can be very helpful, and some simple things that we can do to prevent the spasticity from getting worse. And there's also baclofen pumps is another thing we'll talk about. But there's a whole lot of things available. So first question I try to divide patients into is it a generalized problem or a localized problem? So, and there's some overlap here. So some people will have, commonly with TM, you may have just your legs involved, and it may overlap a little bit between localized and generalized. But generally, generalized spasticity involves more than 2 limbs, localized less than 2 limbs. If you've got 2 limbs involved, you're somewhere in the middle. But when we have a patient with generalized spasticity, this is kind of the approach we like to take. First thing we ask a patient when they come in and particularly if they've had a worsening of their spasticity, is figure out if there's something triggering it. And in particular, and probably many of the patients in the room have figured this out already, when you have an infection going on, particularly a urinary tract infection, if you're constipated, if you have a painful problem, if you have a pressure sore, that's going to trigger your spasticity to kick up. And of course, we want to treat those treatable things first, because oftentimes you can just give a patient an antibiotic for a urinary tract infection and you fix the problem. So we want to figure that out first. Then there are a number of things that we can do in terms of conservative things that don't involve medication, don't involve surgeries, that are really helpful and important. So we want to stretch out the joint. Now, just doing range of motion exercise twice a day or something like that will help a contracture from getting worse, but it's not going to fix a contraction. In order to fix a contracture, we have to do a prolonged stretch. So we often put people in a brace or a splint, particularly a dynamic splint that's spring-loaded that'll stretch it out, or sometimes, particularly in kids, we use plaster casting, that we can put them in a cast like you would use for a broken bone to stretch them out. Positioning is very important. So spasticity is very dependent on what position you're in, and figuring out what positions are right for you to limit the spasticity is helpful. And then there are a number of different modalities, both hot and cold modalities can be effective for spasticity. So heat packs or cold packs, different patients respond differently to those. Or there can be deep heating modalities like ultrasound that can be used to stretch out a thing. And as we learned from Dr. Becker, we can maybe even send people scuba diving to help fix their spasticity. So I have to add that to my slideshow for next year. Then kind of the next step along the way is starting some oral medications, and we'll talk about the options there. The oral medications can work well, but they also have a lot of side effects, so that's one of the big limitations to them. And then if we're not able to control it with the oral medications or there's too many side effects, we can inject the medication into your spinal fluid. Or lastly, there's some very invasive neurosurgical techniques that we almost never use nowadays, but used to be used in times before we had all these fancy new drugs and equipment to treat it. But sometimes we have to resort to that as well. So in terms of oral medications, the big 3 that we use are up here. Particularly in TM, a mainstay is baclofen because it works on the spinal cord. This is a little oversimplification in terms of where things work, because it does have some impact on the brain as well. But for the most part, it works on the spinal cord. and it helps produce one of those inhibitory chemicals that Dr. Sikowski was talking about, GABA. So it will help produce that, slow down the firing of the muscles. Then there's tizanidine. That primarily works in the brain, but can be a good treatment as well for patients that don't respond to the baclofen. And lastly, there's dantrolene, which doesn't work on the nervous system at all. It actually works on the muscle cells, and can also be a good treatment. Each of these has some side effects, and we're often limited in how high a dose we can go in people because of the side effects. All of them, to one degree or another, will cause some muscle weakness. That's probably the most concerning side effect and the biggest limitation we have to them. Both baclofen and tizanidine commonly cause some drowsiness, sometimes even confusion. The dantrolene causes a lot of generalized muscle weakness and can also cause some side effects on your liver that limit things. So they each have their problems as well, but they're a good place to start. When we can't control things with the oral medication, there is an option for baclofen to be injected into the spinal fluid. And what we do with this treatment is there's an implantable pump here that's programmable, so we can change the dose infinitely. We just wave a magic wand over your belly and change the dose. But it sits in your belly, and then there's a catheter that comes up through your back into your spine and into your spinal fluid and injects medicine direct into the spine. And because it goes in the spinal fluid and directly goes to the spinal cord, we get by with a much lower dose, which means there's less side effects and more efficacy. So that's the idea behind it. But it's not for everybody. There are its own set of problems in terms of complications. There can be mechanical complications with the pump. It is a surgical procedure, so there's the risk of surgery, infection, and so forth with it as well. But it is a very nice treatment when it works, and can be a real boom for patients. So what about patients that only have one or two limbs affected? Well, then we use kind of a different treatment algorithm. So we do some of the same conservative management things that we talked about before, making sure that the muscles are properly stretched out, and really work with our physical and occupational therapy colleagues on this. If it involves smaller muscles, we use medications called botulinum toxins, and there are now 4 of them on the market that we can use. They fall into 2 groupings, botulinum toxin A and botulinum toxin B, and I don't want to get into details of whether we use one versus the other, but there are a number of treatment options with those. And they relax the muscles by kind of deadening the nerve endings. If it's a larger muscle, we can use either phenol or alcohol. We actually use alcohol like you drink, or phenol is another form of alcohol, which we actually use a little more commonly in the U.S. In Europe, they use more of the actual alcohol. But we inject that into the muscles, and that actually will kill the nerve endings for a more extended time period. So that works for 6 months to a year. The botulinum toxins work for about 3 or 4 months. But they're both quite effective. So this is a little bit of what an injection looks like. So when we use the phenol or the alcohol, we cause a degeneration of both the motor and the sensory fibers. So both the fibers that go to the muscles and to the skin for sensation. What we try to do, though, is localize it by using an electric stimulator to figure out where the motor fibers are. So we want it only to affect the muscles, because if we affect the nerves, it can cause some burning sensations in the area. So that's one of the big risks to this. But if we do it as what we call a motor point block, we avoid that problem most of the time we can and get a really good result. So in terms of some studies that have been done, this was a recently published study, looked at injecting the gastrocnemius, which is the big calf muscle, and 100% of the patients in this study, I think there were around 50 patients in this study, 100% had effectiveness for 6 months, and even at 9 months, most of the patients still had a good effect. The botulinum toxins can be injected either blindly, just going by anatomic landmarks, or using a similar technique to what we use for the phenol, where we use an electrical stimulator. And as I said before, there are 4 of them on the market now. They last anywhere from 2 to 4 months. Only one of them is approved for spasticity by the FDA, and that one is only approved in the upper limb, and actually only in stroke patients, although we do commonly use it in patients with TM and other spinal cord problems, and it works very well for those populations, but it hasn't been as well studied. So the data is limited in transverse myelitis and spinal cord injury. One trial that was recently done was done in 28 spinal cord injury patients, and as the numbers show here, about half of them had improved gait, but the vast majority got improved positioning, at least in their lower limbs. The results are better in the upper limbs with those smaller muscles. So 78% had improved hand function, 2/3, you were better able to do hand hygiene, able to move the parts so that you could wash it. For example, if you have a clenched fist, you could wash it better. And pain, which is a major problem with spasticity, was improved in 80% of the patients. So this is a good reason to do this too, is if you're having painful spasms, the injection can help quite a bit. So that's all I have. I guess I have a little bit of time for questions, right? Anybody have any questions now? All right, great.
Okay. Well, we're going to go on